In this video, we'll go over types of ionizing radiation for external beam radiotherapy. So there's a few types of ionizing radiation which we'll go over. The first is photons. So photons, when they're ionizing, they can have a range of energies, and we can classify these into different groups in terms of their usefulness for radiation therapy. The first is UV, which is in this kind of lower energy range here, and then superficial to orthovoltage to megavoltage. And just to kind of get a good perspective on this, we can also look at the range of brachytherapy, gamma emission sources, and also what the diagnostic range is that we would typically use for like X-ray imaging. And so you can see here this ranges from, just above 1 eV for the UV range up to about 10 keV where the superficial starts, and then kind of into the orthovoltage range once you get close to 100 keV, up to, in the mid-range a little below 1 MeV, then we start to really transition into the megavoltage range. Another type of ionizing radiation is charged particles. And I've kind of lumped a couple of different types here, and so these could be electrons, they could be protons, or they could be heavy ions. And then the final type of ionizing radiation, which we'll talk about briefly, is neutrons, and they have a few different reactions that are important there. So UV light is technically ionizing radiation. We want to protect against sunburns, which we can get from UV, right? But in reality, it offers very little penetration into tissue, so it's not really useful in terms of radiotherapy. But one thing of interest is that it is used for photochemotherapy. So this is a medical use of UV for treatment of diseases. So there's PUVA, which is treated for skin diseases. This is Sorolin plus UVA light. Sorolin is a drug that doesn't really do anything until it's hit with UV light, and then it can intercalate with the DNA and cause DNA damage. Very similar to that is extracorporeal photopheresis, which is Sorolin plus UVA applied for cutaneous T-cell lymphoma. So it's basically treating the blood, which is taken out of the body and then put back in, as you can see in this illustration on the right. So that's just some interesting medical uses of UV light, but neither of these are really considered radiation therapy. So we won't really talk about these in any further detail. So let's move on to superficial orthovoltage and megavoltage photons. And there are a few important interactions that occur for these photons within matter. These include coherent scattering, photoelectric effect, Compton interaction, and pair production. So this graph here shows what areas the photoelectric, the Compton, and the pair production interactions are dominant. For different photon energy, that's the x-axis, and for a different atomic number on the y-axis. And the next thing we can do here is we can kind of shade in the areas where the superficial orthovoltage and megavoltage ranges lie, and you can see that here. And one thing that we can note also is that the area of the curve that we typically are looking at for interactions in tissue is pretty low on this graph. So the atomic number for water, which is pretty close to tissue, is 7.5. It's pretty low. It's down here at this blue dashed line. Even for bone, which is not which is pretty high Z for tissue, is at around 13-ish. So you can see that's not terribly high on this graph. So a couple of takeaways here is that for most cases, Compton is the dominant interaction for most clinical situations. And the other thing to note is that photoelectric effect becomes important for low energy, so for superficial orthovoltage ranges, and for higher Z, so maybe for bone, or if you were to have, like, say, some type of an implant that was, even higher than that. So this graph here shows the mass attenuation coefficients for various interactions in carbon, which has an atomic number pretty similar to water and to tissue. And you can see that here for the coherent scattering, for the photoelectric effect, for the Compton interaction, and for pair production, as well as for the sum of all of those for the total mass absorption coefficient. And we can also, on this graph, shade in the superficial orthovoltage and megavoltage ranges, so you can see how this changes over these ranges of energies used for radiotherapy. And one thing to note here, as you can see, and we talked about in the last slide, the superficial range orthovoltage, that's where photoelectric effect really starts to become more prominent. And then the other thing to note here is that the attenuation decreases with energy, so you really get more penetration for higher energy beams. So this plot shows a depth dose curve. Basically, it shows dose as a function of depth in water for various photon beams. This includes a few megavoltage beams, as well as an orthovoltage and a superficial beam. And you can see that there is a skin sparing effect for megavoltage beams. This is a key component of megavoltage beams. Basically, the dose starts low at the skin and then increases to a maximum and then starts to decrease kind of exponentially. And this is important because skin reactions to radiation can be prohibitive to treatment, but by having this skin sparing effect, we can give a higher dose within tissue, deep within tissue, and spare the skin in a way that will help us to be able to get a more therapeutic effect. And this is due to the higher energy and thus longer range of the Compton electrons. We can also see that there's better penetration for megavoltage beams, which is what we had observed in the last slide as well. And then just to note where these beams come from, so for megavoltage beams, the source is a linear accelerator, which is most common source for megavoltage. But there's also a cobalt source, which is a cobalt isotope. For the orthovoltage and superficial beams, these come from an X-ray tube. Finally, the KV energies, they're only really useful for superficial treatments. Their use is pretty rare since it's mostly been supplanted by electron beams, which also can be used for superficial treatments. Megavoltage beams are the most common form of ionizing radiation used for radiotherapy.
So let's move on and talk about protons and heavy ions. And we're going to focus on protons because they're very similar to heavy ions in their beam characteristics, but protons are much more common. So they're typically generated using cyclotrons, and you accelerate them up to energies of 70 to 250 MeV to get a usable beam. And the types of interactions in tissue that are important include inelastic Coulomb interactions with atomic electrons. Basically, the proton interacts with an electron, usually an orbital electron, and gives some of its energy to it. It loses a very little amount, and this electron then becomes energetic and goes off and has its own interactions. There's lots of these interactions. The proton will interact with lots and lots of particles along its track and gives off just a little bit of kinetic energy along that path. So it causes what can be modeled as a continuously slowing down of the charged particle. And it does not significantly alter the trajectory of the proton because the proton is much more massive than the electron. And this means that the protons, for the most part, have a very predictable particle range. Another interaction is elastic Coulomb scattering with atomic nuclei. So basically, the proton comes near a nuclei and will interact with it and may be repelled or change trajectory. And so this is less common, but it does have a very important clinical result, which is that there's some lateral smearing of the beam based on the trajectory change in the protons that happens when this occurs. And then finally, there's inelastic nuclear interactions, which is also less common, and this can remove the proton from the beam. It can cause neutron contamination in the beam. So these are some important results from that.
So this plot here shows the stopping power of protons as a function of energy. And so one thing to note here is that the protons tend to lose more energy as their energy decreases, right? So as it gets less and less energetic along its path, it starts to lose more and more energy. So thus, the energy loss is slow at first, but then happens rapidly at the end of a particle range. This has some really important implications for what the depth dose curve will look like for protons and heavy ions. So this curve here shows dose as a function of depth in water for a number of different types of radiotherapy beams. So there's the red curve, which is the X-ray photon beam. We've already talked about photons. And the blue curves are proton beams. Now let's focus on one specific beam, which is this proton beam number 1 here. And you can see that for a monoenergetic proton beam, the dose is at a maximum at the end of the particle range. This is called the Bragg peak. So you can see the dose starts around a little above 20% and then increases dramatically at the end of that range there to above 80% and then falls off to nothing. And so this really is a big advantage for protons. So protons and heavy ions offer a unique advantage over megavoltage photons in terms of achieving dose penetration in tissue. You can give this high dose in the center of the body while giving a low dose at the surface or anywhere proximal to that depth and past that depth. Now, often the Bragg peak is not really wide enough to treat whatever we need to treat, and we have to actually broaden it out. And so we can do this by basically using different energies of protons and spreading out this Bragg peak. And that's where you get those other proton beams like number 2, number 3, and so on and so forth. And if you take all those and add them up, you end up with this spread out Bragg peak to cover a specific range in tissue. And so there you can see this 12 proton beams make this spread out Bragg peak, and you get this nice flat dose where the dose is at a maximum where your tumor is, and then or your treatment area, and then it's less proximal to that and less distal to that as well. So this is, again, a big advantage of protons. All right, let's move on and talk about electrons. So electrons are typically created using the same linear accelerators as those used to make MV photon beams. So this is very convenient, and it makes them very common since we have lots of photon MV accelerators in practice. And the typical energies that are used clinically are in the range of 4 to 22 MeV. All right, this curve here shows the mass stopping powers of electrons as a function of their energy. And there's a few things that we can note here. First off, electrons lose their kinetic energy through collision events. So they basically impart energy to other electrons via scattering. And you can see the curve there up above for those. And then radiative losses, which are basically Bremsstrahlung photons created. Basically, the electrons go in and they kind of lose all their momentum, all their kinetic energy, and they give off a Bremsstrahlung photon. And you can see the curve there for various atomic numbers. And a few things here that are important is that similar to protons and heavy charged particles, electrons tend to lose more energy as their energy decreases. Basically, they have higher stopping power for lower energies. So as they're going along, they're losing energy, and then all of a sudden they'll lose energy quickly. However, they're unique from protons in that they undergo much more radiative losses because they're the Bremsstrahlung interactions that occur. All right, this is a depth dose curve for electrons, basically showing the dose as a function of depth for 6 to 20 MeV clinical electron beams. And so you'll note that this looks a lot different than a proton beam. So in contrast to protons and heavy ions, electrons are not heavier than the particles they typically interact with. They're also electrons, right? So thus electrons have tortuous trajectories throughout the medium, as opposed to protons, which kind of, for the most part, go straight unless they get close to a nuclei. Because of this, their depth dose curves look much different than protons. There's no Bragg peak here, even though they also give up most of their energy at the end of their track. And electron beams also have photon contamination due to the radiative losses in Bremsstrahlung. So you can see here there's a kind of a tail after you get past the end of the range of these particles, and that's not electrons causing that dose. That's the Bremsstrahlung photons causing that dose. And there's more contamination for higher energy electron beams. Electron beams are not very penetrative, so they're used for superficial treatments. All right, the last type of ionizing radiation we're going to talk about is neutrons and neutron beam therapy. So neutrons can be divided into 3 categories. There's thermal neutrons, intermediate neutrons, and fast neutrons, depending on their energy. And if you look at this curve here on the right, this is the contributions to Kerma for various types of interactions, neutron interactions in tissue. Now, it's actually very specific to tissue because it depends heavily on the atomic number here, in the neutron interactions that it would have with that atomic number. And let's shade in the thermal, intermediate, and fast neutron range here. So you can see that depending on the energy of these neutrons, various reactions will be dominant. And for kerma and essentially dose. For lower energies, less than 10 eV, so like thermal, especially thermal neutrons, the dose is mainly due to gamma rays resulting from thermal neutron capture in hydrogen. That's this curve G. And curve G has been, you can note there that it's been placed downward by a factor of 10 to the negative third, just so you can see it a little more clearly. For higher energies, so for greater than 100 eV, and especially for fast neutrons, the dose is mainly due to recoil protons resulting from elastic scattering of hydrogen nuclei. That's curve B here. So one important clinical aspect here is that for a fast neutron therapy, that would be in the fast neutron range, it's going to have higher LET and higher RBE because the dose is caused by protons, which create a lot more events along their track, a lot denser events, dose per along the track than do the electrons that are going to be set in motion by a gamma ray beam.
So one potential source for neutron beam therapy is fission reactors. And so this can be done using a radiotherapy beam port, which basically allows the neutrons to be transferred through this port and can be used for therapy. This is, in somewhere in the range of 2 MeV. And there's also thermal columns, which is basically the neutrons are slowed down to a thermal energy prior to being used. And so either of these have been used maybe for experimental reasons, but these are really the exception rather than the rule. And it's quite rare to have a neutron radiotherapy system based on a reactor.
So you can also have a cyclotron or accelerator that directly creates a beam for neutron beam therapy. And so one example of that is at the University of Washington. They have a proton cyclotron that's accelerated up to 50.5 MeV, and that's directed via magnets through a gantry and directed onto a beryllium target to create neutrons. And there's a few other clinical systems that exist that have mostly been decommissioned now. One was at Carmanos, Wayne State, which basically had a supercooled cyclotron that was mounted directly on the gantry to get rid of some of the bending magnets that were necessary there for a gantry. And then Fermilab also has their accelerator that was used for neutron therapy. But both of those have been decommissioned. And here's a picture showing the system at University of Washington. This is the Clinical Neutron Therapy System, CNTS. There's the treatment room on the left. You can see that rotates around. It looks very similar to like a proton setup that you would have for radiotherapy. And then also the MLC. So they actually had an MLC that you could they have an MLC that you can use for type of IMRT or beam shaping. And this figure here on the right shows the depth dose for that beam. So one thing to note here is that the depth dose curve for a neutron beam, it looks a whole lot like a photon percent depth dose curve. You've got a little bit of a beam sparing effect, and then you've got this dose going, kind of going down almost exponentially after a maximum depth.
So neutron beams can be very expensive to create, and they don't really have the depth dose advantage that protons and heavy ions do. So what's the advantage of them? Well, this really comes down to radiobiology. So fast neutrons create lots of events along their track, which means they have a really high linear energy transfer and radiobiological equivalent dose. And this can be advantageous for cases where tumor cells are really radioresistant naturally. So maybe they are really hypoxic, and so basically the sublethal damage doesn't really translate well into cell kill. Neutrons should maybe be able to get around this with their really high RBE. So one thing we should mention before moving on is boron neutron capture therapy. So this is a really intriguing idea that's been around for a long time. The idea is that you have boron 10, which is uptake into the tumor, and then this boron absorbs thermal neutrons. So very, very efficiently, much, much, much more efficiently than typical atoms. And so the boron absorbs the thermal neutrons and gives off alpha particle, and it creates highly localized damage within the cell and the surrounding area. So this is a really interesting idea, but it does have some challenges. The first is identifying boron compounds that are significantly preferentially absorbed by malignant cells. And second is that thermal neutrons have a limited penetration. So this is a really interesting idea, but it's really still in the experimental stage, and it has been for a very long time.
So now that we've talked about all the different types of ionizing radiation, I wanted to just show this to kind of put all the pieces together. And this is a depth dose curve for various clinical ionizing radiation beams. And you should really be able to tell, if we took off the labels, you should be able to know basically what type of ionizing radiation each of these would be for the most part. All right, thank you very much.